All right, hi everybody. We're going to be covering acute coronary syndrome, or ACS. This will hopefully be a nice primer for you based on everything we talked about in class. I know this is a big topic and it's something that you could probably all benefit from getting a little bit more of a refresher on. So let's talk about what ACS is, right? We went through a lot of this, right? So we know there's different types of ACS, right? We'll talk about STEMI, so ST segment elevation myocardial infarction. We also have NSTE ACS, which includes a couple different subtypes, right? We have those patients that present with non-ST segment elevation myocardial infarction and those that have unstable angina, right? So no matter how these patients present, oftentimes what we're talking about is a plaque rupture, right, that leads to a clot. So most patients that you're going to encounter with ACS are going to be over here in the NST-ACS part. So this is about 70% of what you're going to see in practice versus about 30% STEMI. Now the STEMI patients are definitely at higher risk, at least short term. So let's talk about how these patients differ, right? They're all going to present with some type of ischemic symptoms, right? Think about the typical things, right? Chest pain, shortness of breath. Could be more atypical, more GI in nature. But then how else do you differentiate these different types of ACS? So you have the EKG findings to go off of, right? So for STEMI, remember, based on the makeup of the word itself, these patients have to have ST segment elevations. Whereas over here for NSTEMI and unstable angina, they could look very similar. And you're going to see something other than ST segment elevations. So ST segment depressions, T-wave inversions, for example. And then lastly, you need to think about the biomarkers or cardiac enzymes, right? Is there cell death to the heart? And our most sensitive marker is going to be the troponin. Right? So to meet the definition of an MI, the patient has to have a positive troponin, right? So we know that in STEMI there's an MI, right? So the troponin needs to be positive. What about over here? Well, same over here too for NSTEMI, right? These patients are also going to have a positive troponin. But then for unstable angina, right, this is the key difference, is that the troponin is going to be negative. So how else do these different types of ACS presentations occur? How can we further differentiate them? So for STEMI, we tend to call this one a red clot. And if you'll recall, that's because it is more fibrin rich. And fibrin's the part of the clot, kind of the backbone of the clot, that's going to trap red blood cells. And because of that, you're going to be more likely to see an occlusive clot. So we think about rapid reperfusion to open up the vessel that's completely blocked and to save as much heart muscle as we can, right? So time is muscle. And so start thinking about, how can we open up the vessel very quickly, right? We can do it in the cath lab with a stent, or you can do it pharmacologically with a fibrinolytic, which would only be useful for STEMI. Now over here for NST-ACS, right, these patients typically have what we call a white clot. So what does that mean? So these clots tend to be more platelet rich. And because of that, with having less fibrin, they're oftentimes subocclusive. So really what that means for the way we treat these patients medically is that we're not going to give a fibrinolytic over here because it's not fibrin rich, it's not going to be that useful, and it's going to lead to more adverse effects such as bleeding. But everything else that we talk about in this class for treating ACS is going to apply to all these types of acute coronary syndrome, which we'll get into next. So let's go through what our different modalities are for treatment. So the first one you'll always want to think about is reperfusion. Right, so reperfusion would include either PCI, percutaneous coronary intervention, which is going to be superior in most cases, right? The only time it's not going to be a preferred strategy is if you can't get the patient to the cath lab quickly, right? If you can't meet that door to balloon time goal of less than 90 minutes. So if this can't be met, then you're going to be looking at using a lytic, but for STEMI only. Now, even for the patients over here with NST-ACS, they still may benefit from PCI. But the urgency is going to be less than it is with a STEMI patient, and if you can't get them to the cath lab to do PCI, fibrinolytic is not going to be an option for an NST-ACS patient, only for STEMI. Okay, so that's kind of step one, right? So beyond that, let's talk about other medication classes that are really important for these patients. So I tend to think of this next group as being the anti-ischemics, and you've learned about a lot of these, right? A lot of these are antihypertensives as well, and they're very useful. So we'll come back to that in a moment. We also have another class, and remember the A, right? A lot of these do start with A, so antiplatelets. So what's next? So hopefully you'll remember our anticoagulants as well. And then we get into some others, right? So don't forget about your cholesterol-lowering treatments, which will include our statins, particularly high-intensity statins. And then I'm going to call this next one some of our other classes, which would include our RAS inhibitors, right? ACE inhibitors, or if a patient can't take an ACE inhibitor, then an ARB. And for some patients, it's also going to include aldosterone antagonists if they have other high-risk features, which I'll talk about in a moment. So how can we help you kind of remember this a little bit better? Right, so when you think about those really early medications that would help patients, especially to help them feel better, help treat their ischemia, there's that useful mnemonic called MONA-B. Right, so what is MONA-B? So the M will start with morphine, right? IV bolus, which could be useful, right? A lot of these anti-ischemics are going to either help improve the delivery of oxygen to the heart by vasodilating, or decrease the demand for oxygen on the heart by slowing heart rate or lowering blood pressure. You do have to be cautious with the morphine, though, because of respiratory depression. Supplemental oxygen, right, is going to be an option, especially if patients are hypoxemic. We have nitrates, which are going to vasodilate, relieve symptoms. So these will be really helpful, right? We can give nitroglycerin either sublingually or as a spray, or as an IV drip. And then we have the A for aspirin, right? We want to give that higher dose initially, non-enteric coated, make sure it works as quickly as possible. But the A can also be a useful reminder for other antiplatelets. So remember DAPT, right, or dual antiplatelet therapy, which would include our P2Y12 inhibitors. So we have several medications there as well, right? Clopidogrel, or the more potent alternatives like prasugrel or ticagrelor. So we want to think about starting those early as well, because those are going to be very useful and help improve outcome. And the A can also be useful to help you remember anticoagulation. So kind of back over here, frequently in the hospital we do use unfractionated heparin, but you have other alternatives as well, such as enoxaparin, or even bivalirudin if it's going to be used in the cath lab as an alternative to heparin. Right, we have statins, so think high-intensity statins. We want to think about an example regimen like atorvastatin 80 milligrams, which has that pleiotropic effect and would work more quickly than just the lipid-lowering effects, which takes a little bit more time. And then back to the RAS inhibitors. Again, ACE inhibitor, right, if patients can take it. This is especially useful for those patients that have an anterior wall MI, that have LV systolic dysfunction, so they're at risk for heart failure. Okay, and then the other option for RAS inhibitors is going to include aldosterone antagonists, so specifically spironolactone, which you'll recall if the patient's already on a beta blocker and an ACE inhibitor, they still have, for example, a low ejection fraction and they're at risk for heart failure, or they have diabetes, then this could be an option in the way of spironolactone. So I hope the session was helpful. Good luck. We'll see you in class and talk to you soon. Thanks.